Invite him to render the oration and do the honors. No, sir.
Good morning to everybody. On behalf of IAP TNC, I welcome one and all for this wonderful oration by Dr. Mahadevan sir. And before that, I want to introduce the award. Professor C. Jayaraja NADAR oration was one of the, Professor C. NADAR was one of the senior most pediatrician of Eastern years, hail from southern Tamil Nadu. He chose to become a pediatrician under the guidance of Professor S.T. Achar. He started the pediatric department in Kilpauk Medical College and was instrumental in starting the DCH course. He retired as professor and HOD of pediatrics of KMC, Chennai. He was a very humble person and a good clinician, good teacher and a very soft examiner. After his sad demise, his family members contributed a sum to start an oration award in his name, and it was unanimously accepted by IAP TNSC and is prepared the memory of Professor Jayaraja NADAR, our state branch, and it was instituted at the prestigious oration award in his name. Next slide. Next. And Professor Dr. Mahadevan Subramanian, and he has done MBBS and DCH and MD Pediatric Medicine and PhD Pediatrics, M.A. MS, all from JIPMER. As the best outgoing graduate from JIPMER 1974 and training in pediatrics 1979, and he is a retired Dean JIPMER September 2013 to October 2016, and he was head of the Department of Pediatrics and head division for pediatric critical care JIPMER from 2015 to 2018, and now is a professor of pediatrics and director at the Venkateswara Group of Institutions, Ariyur, Pondicherry, and currently is Dean Research and PG Studies, Sri Venkateswara Medical College Hospital and Research Center, Ariyur, Pondicherry, May 2020 onwards. And he is from February 2021 onwards, he is a chairperson of Ethical Committee, Tamil Nadu, Dr. MGR Medical University, Chennai. And from August 2021 onwards, he is a member Task Force for Right to Health Policy, State Planning Commission, Government of Tamil Nadu. And 2017 onwards, he is a member Academic Council, Sri Ramachandra University, Porur, Chennai. And from 2015 onwards, lead for starting MD, DM, Pediatric Critical Care Program at JIPMER. And lead for starting postdoctoral fellowship in child and adolescent psychiatry. And he has received so many honors and like Professor Arnold H. Ainan Endowment Oration and Mehta Oration and Pediatric Critical Care at Chennai. And he is having lot of credentials like 125 international publication and national 100. And he has written textbooks, almost 10 textbooks. And so now I welcome sir. On behalf of IAP TNC, really honored and really happy that we are giving oration this year. Thank you.
On behalf of IAP TNC, we are profoundly honored to honor Professor Mahadevan sir. I request all of you to stand up and give him a standing ovation.
I request the orator, Professor Dr. S. Mahadevan, to deliver his oration talk on clinical care, training and research in pediatrics, some personal glimpses.
Very good afternoon to one and all dear friends. Esteemed President of the Tamil Nadu AAP chapter, Dr. Ismail, Dr. Rajendran, the Under Secretary, Dr. Gopal Subramaniam, the Treasurer, and the past President and my good old friend, Dr. R.M. Sendil, and the team Puduvai Pedicon, led by Dr. Thiruburugan and all other members. Thank you for your kind words. I am extremely thankful for this singular honor and also humbled to receive this oration award. Before I get into the main topic, I sincerely apologize for some abrupt interaction I had with Dr. Pandruti Krishnamurthy, Dr. Ilamaran and Dr. Dakshayani sometime yesterday. I'm sorry for that. Dr. Jayaraj NADAR oration, I'm informed by Dr. Ramesh, who had been his student also, who had been, Dr. Jayaraj was his examiner. He was one of the AB pediatrics of Tamil Nadu. At that point, there were three people, Dr. B.R. Santanakrishnan, Dr. Ramaswamy from Coimbatore, and Dr. Jayaraj Nadar. They were the American board certified people who started serve and bring the best of the pediatric traditions to the country, to this part of Tamil Nadu. And I'm thankful to the Jayaraj Nadar family for this award. Of course, KMCH is a thing by itself, especially with Dr. Jayaraj Nadar starting the pediatric course, Dr. Matangi Ramakrishnan, who started the plastic surgery course. So there are a number of things, so much about these institutions in Chennai. Each one has their own things to say. So please permit me sometime to be bilingual and also during certain points in the oration. And the next 14 slides, it will be a visual tour of the friends who made my journey, who made my learning and work ambience so pleasant and so memorable. Friends accept you for what you are and for what you are not. So thank you very much, all my friends, whom I am going to introduce in the next 14 slides for your strength to me. So the Academy, its present office bearers, the Puduvai Pedicon team, and to the friends in my journey, I am humbled and I am so grateful to all of you. Indian Academy of Pediatrics has grown from strength to strength. And if you look at 1976 was the year when I decided to enter into the specialty of pediatrics with Dr. Shanti Ghosh as the president. And the writing was on the wall that it is going from strength to strength. And now, yesterday we had Dr. Bakul Jayant Parikh, now Dr. Ramesh Kumar, who was also with us. So, Indian Academy of Pediatrics is a very strong body, and I think it is one in which every aspect of, say, clinical care, teaching, research has gone from strength to strength thanks to the tireless efforts of all the office bearers, not only at the center, but also at the state level. And thank you very much. And I think this is the strength which they have silently given to all of us. Yes. a familiar figure or even a household name in the last 2 years, Professor Vinod Paul, who was the head of the department in All India Institute, and of course now for the National Medical Council and also a member of Niti Aayog. They used to call him as the vaccine roll-on man. So it was an association which made me learn certain things of planning, and especially when he was in the Melinda Gates Foundation. Very familiar figures. Remember that it is not that when there is a specialty and then there is a subspecialty, it is not that subspecialty people are taking things away from us. They are making our things easier, and we are delegating certain aspects of our care. So there is no rivalry between us because we all work for a common cause, and that is for the betterment of the people. And of course, Venkatraman Shekhar he was a JIPMERite, and then now he is in US, and ventilation man we call him, and pediatric ventilation, and all things on research methodology, all the Zooms, you would have met Dr. Shekhar Venkatraman, and of course, Bala Ramachandran. I don't require, I'll be carrying coal to Newcastle if I have to introduce all these members with Dr. Sunit Singhi there, Dr. Bakul Parikh and Dr. Santosh Sons in the central office. I think it is this kind of a commitment which has made Indian Academy of Pediatrics what it is today. Thank you, sir, and also I think our newly elected president and Dr. Guna Singh, yes. I think Dr. Guna Singh and Dr. Parsarathi, Dr. Nagaraju, they all always carried the picture that, you see, Tamil Nadu is down south, but it doesn't mean that we are not ignored now. I think in that way, thank you very much. Then, my close friends, I think you would be meeting all of them here. They would be amongst us. And Professor Srinivasan, my head of the department at JIPMER, Dr. Virudagiri, whom we had known, and I think he's from Kumbakonam, and his community work, especially on nutrition, is phenomenal. Dr. Sriram Krishnamurthy, who is now making a mark in pediatric nephrology, along with Dr. Arvind Bagga, and yes, PRC, yes, he is a year my junior. Dr. Ramchandran, and who is also now in a number of committees, and he was now the dean faculty at Srihar. Thangavelu, no need to repeat. Dr. Gauri Shankar, Dr. Nedu, the Dharmapuri College, as well as the research methodology, I think he was there, and our Jayaraja. Thank you, sir, for always being a support. Whenever we interact, it has always been a pleasure. Yes, silence is eloquent, and I think the way in which this particular conference has taken, hats off to both of you, sir. Sorry, I think, yes, Basavaraj, he was with us yesterday. Dr. Meera Ramakrishnan, Dr. Rajendran also with us, and I think this is how I think these interactions in these meetings, I think it has strengthened us, and I think there we are not talking to people, we were talking with them, and I think that is what has strengthened our association. Thank you very much, sir. Of course, Ibor, he was there yesterday, and all workshops on emergency pediatrics, it was also made a mention by Dr. Somashekar now, that everybody is now starting this emergency course as an entry criteria for internship. So I think this is the team. And you see this Italian person, Dr. Mararo, he is basically an Italian, but he's settled in Goa. He used to come periodically in every pediatric conference. I'll be surprised if Dr. Mararo is not there. And of course, Frank Shan, who's also the thing of critical care from Australia and the World Pediatric Society. Yes, the team, the vibrant team led by Dr. Thangavelu, Dr. Sashindran and others. Thank you very much, Professor Nalini, for showing us how to handle chronic problems through your examples. It is that perseverance. And Dr. Chidambaram Ramakrishnan, I think, who had been my teacher when I joined JIPMER. She was the Department of Physiology, and then later on she became the head of the neonatal unit in Pondicherry General Hospital. And thank you, Dr. Chidambaram, for doing that. One thing also you must know, she's a bard. She writes beautiful English poetry. Thank you, madam, for being with us. Yes. Dr. Singarvelu, who received the honor just in 2020. And thank you, sir, for being with us. And of course, the young team. It is the wisdom of the old and the agility of the young which makes all the difference to your workplace. The person from Kanchipuram and Dr. Narayan, who's with us in Jipmar. Fine. So that I have taken you over the people who strengthened it. Now, how to balance between clinical care, training and research. These are three roles in which it may be a tightrope walking, in which how much importance to give to each so that one does not get neglected at the cost of the other. Patient care is your stamp. That is where, naan the doctor da naam paakanu. Avar da naam paapan. Okay, even they may show to everybody, but then at the end of it, they will ask, where is he or she, depending upon the amount of care, patient care which you have given. So this is the stamp of your training. This is the stamp of your working in pediatrics. Basically, all these three are like gears. The size and direction or the movement may be different, but we all now know how to steer vehicles. So I think this is the way, change the gear depending upon what the situation demands. Of course, in clinical care, there has been a shift in recent times, which I will share with you in the next few slides. And of course, communication in clinical setting. Now, when a child and a family comes to you, it is not only the child and family are frightened, even healthcare team is also frightened, because it adds on to your mortality or morbidity data or a chronic morbidity data. So it is a healthcare team, but I think we cannot afford to express our anxiety, and at that point, that is where your training makes you perfect. So it is the small module clinical training which is going to make you perfect, and you are very confident, okay, if this case comes, I will be able to give my best to it. So in clinical care, it is the understanding what is going on. Like today we had excellent papers from the SCORE, which has been done for bronchiolitis, for dengue and everything, and also in COVID and related to that, how to interpret these antibody titers. So it is this understanding what is going on is going to help us. And of course, clinical decision is not a complex process. It is not all that easy for somebody to take a decision. Even it takes a long time before a family decides to take a child to a hospital, and that to which hospital. If it is an emergency, they will reach the accessible, the nearest one. So clinical decision making to arrive at a diagnosis, to which protocol, because protocols give you a direction where to take him. I think it is not as simple as we think. Once I say, sir, yes, it has to know. It is not all that simple. We say, now from the MCA has, the National Medical Commission has said that you must go to what is called skill building, right? Those days, number article, amical, which we will learn to do a lot of things. But nowadays, homemakers have to now understand the integrity of a mixie, and something goes wrong, whether she herself can troubleshoot it or with the help of these things. So it is a question of skill training, which is very important in handling machines. So, but another equally important skill which should come to the medical trainees is listening skill. Listen to your patient because he is telling you the diagnosis. Sir William Osler. Of course, he also told one other statement. The philosophies of one generation become the absurdities for the next generation. Of course, okay, change is the only truth of life. So, but at least listening to the patient, I think this is something which we can do. And I think we will say that the listening is like an afferent limb, and the questioning and answering is like the efferent limb. It is this kind of a balance between this afferent and efferent limb which strengthens this communication. I always say that you cannot bring out the best qualities in a bull by showing it a red cloth. So what is important is, so what is very important is we need to go through this afferent and efferent limb in a way in which you consider best. You see, no one can be perfect, but at the same time, what one says need not be your cup of tea. So many errors in diagnosis and treatment can be treated down to poor listening. But at the same time, if you look at a Harvard study, we said 40% of errors which happen in a hospital are medication errors. Yes, the world where we lived for a long time, nearly more than 20 years, what 21? Professor Srinivasan, Dr. Ramchandran, Dr. Nalini, and all of us know that this is the Ward 21 of pediatrics. Now, things, infrastructure has changed, but nothing, these things have not changed. We have 2 ears to listen, 2 eyes to look, 2 hands to examine, and 2 hemispheres to deduce. Okay, people nowadays come to us with internet information, so it doesn't mean, but then this is our cup of tea. Listen attentively to the mother. Yes. They are our textbooks. Textbooks do give. Once you look at certain things in a patient who comes to you in emergency or in the ward, go back, look into the textbooks, whether what textbooks has given, is it what you have seen is also, people have written through that experience, whether it is Achar textbook or later on what other books have come, O.P. Gai, Piyush Gupta and all these things. Now, yesterday also we had a book release from the professor at Coimbatore. So, patients are our textbooks, in which one had come with a frothing pulmonary edema and the other one who had a bitten limb in which the care had to be given in the ICU. In pediatrics, most of the admissions are emergencies. 80% of our admission problems are related to either a genetic problem and emergencies, and genetic sort of a run determines the way things take a course. So view hospital admissions against home circumstances, the strength of the domiciliary services which are available near, and now this is going to be something so much strengthened in Tamil Nadu. Now I think this domiciliary services is going to be very good because you are training, like yesterday, Professor Ismail was telling about how he had organized 30 courses for the practitioners on these small modules. So thank you, sir, and I think this is the need of the hour to strengthen the domiciliary services. So charity begins at home and then it goes elsewhere. So and I think this is where I think the strengthening of the domiciliary services is going to make a difference. And of course, nature and severity of the illness, we are going to talk about grade 1, grade 2, grade 3 severity. And so this classification, because once you classify things, the way to do things become easy. And I think that is the usefulness of classification. Of course, hospital management may have their own sort of a perception about patient admission and other things. But the ground reality, so that's why I made in the initial thing, admitting a patient or treating a child is a complex decision. So the next thing is, we always say that whenever we are posted in medicine, we always say ACS, acute coronary syndrome, and then we will say golden hour. Before this should rush. Before this, he must be thrombolized. So all these kind of golden hour exists. But this golden hour exists for 2 important rural medical emergencies. One important rural medical emergency is snake bite, and our Professor Ismail, and then a lot of papers now, so much of things are coming, and in fact snake bite attracts a newspaper column every day. So that is the thing about snake bite. And now, of course, jungles have been made into concrete jungles, but that is inevitable in development. But at the same time, we can understand that snake bite also requires a golden hour treatment. And this is the pressure immobilization in which the tourniquet is felt so tight, or people take one black stone and then go and apply it there and then ask the family, velila poi konjam aavin paal vaangitu vaappa. Then they will put that stone into that milk. Adu blue aidichuna, it is poisonous. It is non-blue, it is not poisonous. And then one more, even TV serials keep telling, on the night pura, and the thugada irundaduna, the venom will go away. So you understand that there are a number of myths and beliefs about these things, and if these beliefs are going to take care of the golden hour, well, I think things are that's not science. And of course, this cutting. They will do the cutting, suck it out from the mouth and then put the tupata like the Bollywood movies. So these are all the things, and in northern you have these prayers. I don't say anything, but these are not first aids. When we go for sensitization programs to the rural people, we'll say, I think neutralization of the venom, to look at whether it is venomous or non-venomous. And I think that is what is important. And this becomes a very important aspect of prevention of complication. They will say the doctor should have the eyes of an eagle. And now, if you look at this great bite, this child had his dinner, then morning, suddenly around 3 o'clock, they had a vomiting and some abdominal pain. The father has to go for work at around 5 o'clock. அம்மா வெளியில் போய் ஒரு சோடா வாங்கிட்டு வாங்க. Because that's the immediate relief which they give. So the child drank soda and gave one appam. And then father said, okay, I am now going to hospital. And then in another just 1 hour, with the legendary speed with which the venom progressed, the patient was already having a respiratory arrest. So when they brought into the emergency, it is this particular small, காதுக்கு பின்னால ஒரு சின்னதா ஒரு இது இருக்கு. This is the only telltale evidence that something has happened and this patient was going into a respiratory failure secondary to crate. And what could have been a very bad morning to the child became a good morning with the infusion of ASV. And of course, crate has got another important thing, especially about locked-in syndrome, about which all of you would have known. So very important thing is, it is this clinical acumen, this artificial intelligence, or let us say your Google algorithms will not give. It is only you. It is that deducing from the cerebral hemispheres, this is what can happen. So very important in this thing. Of course, another important self-limiting rural medical emergency is scorpion sting. Scorpion sting makes autonomic storm. So you have both parasympathetic, so priapism, or you have sympathetic, in which you sweat. You look at the way as which, some hair oil pota madri, it is locked. So you remember, and one more important thing about this child, he is staring at you. In children who are just staring at you with a scorpion sting, we have usually found that they have a hypertension. Of course, they can also go in for a hypotension because they have what is called a skin diarrhea. With so much of sweating, so much of vomiting, they can go in for a hypotension. So you need to now know what are the ABC of emergency care. So I don't have to dilate further on that because you have had many sessions on that. Ladies and gentlemen, I think we have moved a lot from when I entered this thing from 1976, in which I learned from the seniors, but nowadays I must also know how to handle equipments. So from a state of intuition, we have now gone into a state of instrumentation. So the instrumentation, this is the emergency unit in what is called the zero delay ward of where I had worked. Jipmar, and you can just see, even if a newborn comes, you have a place to immediately accompany it and then do that thing. And the airway maintenance is the most important thing, airway, breathing, circulation. And of course, handling these equipments. And the sisters are very well equipped to handle all these things. So next thing is about this oxygen, okay. One thing which I had always found, I think there used to be one book called Vakil and Golwala book in medicine, in which it used to say treatment of pulmonary edema. They will say modal, morphine, oxygen, aminophilus, digitalis, and Lasix. You give these things, it will be all right, pulmonary edema. But remember that sometimes in scorpion sting, this is the child who came with that scorpion sting pulmonary edema. And remember, do not assume such patients to be fluid overloaded, so that by giving furosemide, you can do things like that. The diuretics may be harmful. You improve the cardiac output, your urine output may improve. So what is important is that cardiac support, which need to be given for these children who are not going to, respond to your initial management. Of course, now, along with the instrumentation, now, in fact, echo has become an additional clinical test only. For a urologist, it is just not only per-rectal examination, but just looking at this through a echo, it has also become an additional test. And same thing about the things, bedside echo, it has become a routine requirement in any intensive care unit. Portable ultrasound, and then students to be trained to interpret these things, because this is just an additional clinical test. Yes, if at all the knowledge or the practice for scorpion sting came, it came from this unknown warrior, the great hero, Dr. Himmat Saulabh Bavaskar. In 1990s, I think Professor Srinivasan may recall, he was the president of the IMA of Pondicherry. At that particular point, we had a medical audit in the department in which, in the maasam enna 4 case tel kadi vandirukku, ellam settu pochu. Then in the medical records, we have to go and complete the case sheets and write the final diagnosis. So when we were reading that, last minute somebody's sister's note has written, the child was gasping and an ascaris came through the thing. Sir, the ascaris encephalopathy, sir, why don't you put it as ascaris encephalopathy? How can it be scorpion sting? So when this kind of a thing was taking place, we were not sure what is really happening. But only problem is we had never looked at the Lancet publication of 1982 by Dr. Bavaskar. And I think it is the time when we talk to him about these 8 cases, we are not sure as what is happening. He said, this child must have had a mini myocardial infarction. Remember, any patient who has a myocardial infarction, if he wants to go to the toilet, be very careful. It is not that because he wants to go to toilet, he has a sudden relaxation of the anal sphincter because of his hypoxia, and then he goes into that. So one has to be very careful. This is nothing but a mini myocardial dysfunction which takes place in scorpion sting. So maybe because of that and ascariasis is a common denominator in our population because we deworm universally. So it was not ascaris encephalopathy, it was nothing but a myocardial scorpion dysfunction. To get this enlightened, I think Professor Bavaskar had helped us. And look at being a practitioner in Mahad region between, say, Goa and then Mahad in that region of Maharashtra. He has had publications in Lancet, BMJ, and then in NEJM. So I think that is the thing. And I think when he came to Pondicherry, this was the old building of the Aurovilla. Of course, it is still there, but the things have modified. He visited our OPD also to show a number of things. And you can see that this is what he said, transport. Transport has completely changed now. He gave me this particular picture of, this particular picture of rural medical emergency. This is how people are still carried in some part of the country, but now this has changed to 108. I will come to 108 story slightly later. Now, remember, what is important is monitoring. It is that monitoring which predicts the outcome. And yesterday we had very beautiful sessions in which we talked about this monitoring and predicting the outcome. So, a hand on the pulse and a look at the patient. And of course, tropo, CPK, MB, your ultrasound, all these things, if it is available, this I used to call it as a scorpion package. If this is available, well and good, if you have it. But if you don't have it, it doesn't mean that you cannot treat. And I think that is what I want the residents and the students to know. I mean, do with what you have and then probably work on it to improve the availability. Because the policies can be very well defined, but the implementation has its own roadblocks. So in that way, monitoring and guiding therapy is important. You can have a minimal availability or you may be adequately enabled, but it doesn't mean that if you don't have these things, you cannot treat it. Yes, just like Dr. Bavaskar, this is another person who energized the situation of snake bite in the country. He's an herpetologist from Oxford University who called for a meeting because he found that the snake bite mortality is very high in India, and he in fact saw to it that the then Union Health Minister convened a meeting on snakebite protocol in the country. In fact, he waited in the waiting room of the previous Health Minister who was, and then he got it in 2006 and 8. So Dr. Ian Simpson, he came and made us understand about the snakebite and its protocol. But now this, so I don't have to dilate much on the snakebite guidelines, which has now got a second edition also in 2016 with workers from Kerala and especially from Calicut Medical College. They have also contributed a lot to it. So pediatric snakebite envenomission is now more or less a streamlined thing. But the only problem is the government will only say, I will give you, your RMOK will sign only for 4 vials. Especially in Odisha, I think Dr. Sriram is here, and I think he used to tell me, sir, we tried, you cannot get that 8 vials thing which is required. They will give only for 4, and then this thing. So if 1 is better, 2 must be, 1 is good, 2 is better, and 3 may be best. So that is how they go on an ascending scale of anti-venom. But now the venom does not wait for that. Either you have to look like a Clint Eastwood movie. Either you take your thing and shoot him first, otherwise he will shoot you back. And I think that is what the venom is doing. The venom will already do an end organ damage, and by the time you do the venom neutralization, it may not take place. So that is where the aggressive therapy has to be thought about in snake bite, and not too much. But at the same time, this is the evidence which is available that 8 to 10 vials it should be the initial dose. So now this about this 108, there was a British worker who was in, I think some of you would have heard this particular thing, I am repeating it again, how 108 came into India. And of course, now this is the best form of transport. Our late President Abdul Kalam, the Honorable President Abdul Kalam was there in that particular time. This British worker who was working in a pharma in Hyderabad was going for an evening walk, and at that point she got bitten. I also used to tell my students, whenever you go for a walk or anything like that, don't go in bathroom slippers. Go through in protected shoe wear. It is not that wearing shoes is for fashion. Shoe is for your own protection. So in that way, you will not get bitten. She got bitten by a snake, and by the time she could reach I think she went into a neuroparalysis. Then they took her to the nearest hospital. Then they said, no, we will not treat snake bite here, because in case she dies, the postmortem will be done only at the district hospital. So please take her there. Then ultimately, by the time she reached, of course, she reached the other side of life. So, but being an external affairs problem, this thing went up to that time, the Chief Minister, late Dr. Rajshekhar Reddy. And then he said, yes, I accept what it is. But what I can do is, I can provide money for the fuel for transporting them fast. So every primary health center was given some fuel money to transport these ones. And of course, this was well utilized both for antenatal care as well as for snake bite. So ultimately, okay, whatever has happened, things have changed, things are changed for the good. So, and I think this is the story. And then after that, you understand the Gujarat model of Sanjeevani, and then so many other things have taken place. Now, 108 is now a tale to stay. The other thing about ASV is, many times I used to ask people, why you are having ASV, you are having everything. I mean, primary health center doctors are very capable. In fact, so they can even intubate and then they can send it. But please, if you are referring to another place, protect the airway and then send. Because by the time some of these crates reach our hospital, they are already aspirated, and then it is very difficult to get them out. So protect the airway at least. But then you'll say, why you have not done? Illa sir, adha reaction edavadhu aachina ellarum vandu koondittu engala adika aarambichiranga. So it is better that we want to take them to the nearest hospital. And why there was a delay, they will say, we want to give test dose, sir. Now, for this particular thing, I have written down my thoughts. I will share it with you. What you are seeing here, can anybody understand what is this? This is a pit stop. We know about Karthik Narayan doing formula race. So this is handling anaphylaxis is something like looking at a pit stop. Many Indian doctors do not treat snake bite due to the fear of anaphylactic reaction because they say your ASV is polyvalent, it may not be very pure, so quality issues. Because the international bodies want to sell you monoclonal antibodies. Monoclonal, this thing, a monospecific serum, which of course we cannot afford. So we can only afford polyvalent serum. So if anaphylaxis is treated early, then it can be overcome. It is something like a pit stop. People, when they are going for a formula race, they stop in the pit. And during a pit stop, you have other matters to deal with like petrol and tires, but the race is important. Karthik Narayan doesn't stop once he goes into a pit stop. After that, he starts and going through the race. Similarly, I think in the shortest possible time, handle anaphylaxis and then further continue to give the infusion. So it is the same with anaphylaxis. When it starts to, you have to temporarily halt the ASV until the reaction is dealt with, and we want the ASV to running to neutralize the venom as fast as possible. The faster we deal with anaphylaxis, the better. Now, is there any way to find out whether you will have anaphylaxis or not? No, no test dose, because this particular reaction is complement mediated and not IgE mediated. That which is IgE mediated, you can predict anaphylaxis, whereas when it is complement mediated, so there is no use of wasting our time giving a test dose. So intradermal dose is not required, so it is not IgE mediated like the other allergic reaction. And it can pre-sensitize, and we have definite protocols. So whether you need to give IV hydrocortisone along with subcutaneous adrenaline, well, opinions differ. And of course, 2 studies have been carried out, and especially a powerful study from Sri Lanka came, in which David Worrell from the Oxford University, he wrote the textbook of Oxford Textbook of Medicine, he wrote, and then he says, of course, the evidence is still not there, but then you go as per your individual conditions. So remember, prophylactic regimes are optional, but adrenaline, IM, 8 minutes. I mean, that is very important, not subcutaneous adrenaline, which we used to give for asthma before. 2 doses and maximum more than 3 doses we have not required to handle anaphylaxis. So be confident to handle anaphylaxis and don't say, no, this patient we cannot give a ASV. Okay, now communication. Now that we have talked about certain aspects of clinical care which are very relevant to our population, now one thing about communication. I'll give you 2 examples, a fatal communication errors in which it was probably a palliative care ward or something. The milk drip, please give a milk drip. And the sister gave this milk drip IV. Then somebody wrote in this thing, injection plain insulin, 10 units, I think the person who was in a hurry, maybe he had a phone call, maybe something was occupying his mind, then he just wrote a 10 ml IV. Or whatever was written as the sister interpreted it as it is 10 ml, and then she straight away gave, because she said, I am a new person who has been recruiting. And so these errors can be fatal. So communication doesn't just mean only the verbal exchange or anything, but I think these things happen. And then after that, we will be putting them in our mortality meeting. So as I said, the science of communication can be learned and it should be taught. And then there are communication modules available. So what is happening is we have now different skills, but soft skills also need to develop. It plans to clear misunderstanding and practice of a shared decision. I think that is where the strength of our digital IAP is coming up with Dr. Bakul Parikh and then Dr. Ismail. All of them are trying to promote this digital IAP. Through that, I think we will definitely have things different. Now, the next overview about this, one is we have finished clinical care and communication. The next point is about teaching and training. Real life learning and simulated learning, which is better? We can go on a pro and con debate, but the main problem, as I said, is challenges, is the implementation. And research can be basic, it can be applied, or it can be translation. I think you may remember, he was a vice president of our Indian Academy of Pediatrics, Professor Rajeshwar Dayal from Agra, and I think he had come, this is the traditional way of handling a class when he came as visiting professor, shared his experience, and this is a traditional way of learning. But medical education in India has gone through a thorough change in which theory and didactic lectures, now webinar, then OSCE, then modular teaching, and SIMU education, which is always there. And of course, the medical student has to be treated as a part of a medical team. And when he feels as a part of the medical team, then he works better. Suppose he is only made to say, go and get that investigation, go and get the signature from these things, then he may do it. It doesn't mean that it is something less. Even if situation comes, you need to do a safai job also. That doesn't make you inferior. Nothing is inferior as long as it is for patient care. But at the same time, when he is feeling as part of a medical team, then with that hierarchy and other, there are some institutions in which, they will say, you cannot sit in front of me. You have to keep standing. So I think even in cloth shops now, they have removed that thing, that people need not stand for a long time and give to the thing. That rule has come. So, but there are institutions in which, based on hierarchy, you cannot do that. So treat them like your own colleague or your own family. So works like a resident during clinical rotation, and DIAP initiative is going to definitely help. Of course, now there is a digital happiness. Everybody is now happy. In fact, some of the students now say, sir, in the digital class, we are able to learn better than sometimes in the class. In the first bench, in the classes. So I think this particular change, whether it is going to be things, so we'll have to act according to the situation. Of course, competency-based curriculum I have already talked about. Then the analysis of medical literature, chart audit, and monthly mortality morbidity meeting. This has come very much in the newborn care as well as in many of the hospitals. And NMC has now put it as an important requirement in your day-to-day activity. SIMU education. I think every institution now should have a simulation lab. Okay? The adults, there are physiological models also, so it all depends. It all comes with a cost, but doesn't matter, but it's also a way of learning. So hear and forget, see and remember, and do and understand. And I think that is what SIMU education has its own plus point. So the core skills I have already talked is critical thinking. They must have a clear reasoning. At the end of the rounds, a senior PG should say, sir, this is how I think. This may be the differential diagnosis. Otherwise, most of the time when we go for rounds, they will just say, they will show the case sheet to me. They are even so tired. I don't know whether they are so tired that they cannot even say what they will say. Creatinine value so sometimes I feel that if this is the way things are going, at some point or other, you throw up your hands and say, okay, what will be like that, we can still go. But that is not the thing like that. Is this the way in which we got trained? This is the way in which AYYA, NADAR or Dr. BRS or anybody, they brought us up in the pediatric education. So, of course, we will say there is no single best method. Medical education costs a lot, but clinical care and research generates income. But how a thing has to be done is in our hand. Dr. Nalini, I think she had told us how to train and handle chronic illness. Some people are, the emergency is their cup of tea. For some people, say ambulatory care or OPDs, they feel very comfortable. And then there are, you require skills to handle chronic illness. So let me classify and say for blood, you have to have a hemophilia thalassemia clinic. In fact, at that particular point, I still remember Maulana Asad, I think even they will just say about in the wedding, every wedding card should have an inclusion saying that prevent thalassemia checkup. Because there are certain belts of West Bengal in which, thalassemic genes are so widely popular. So even before marriage, as in marriage counseling, I think they start doing it for thalassemia. And anemia, for reasons known or unknown, now we have a lot of elderly population, females with anemia. And of course, children, we have this. Then CVS, congenital heart disease, biliary atresia, then cerebral palsy, very low birth weight infants. So this is the list for handling chronic illness. So whichever is your cup of tea, you can handle it. Syndromes, handling Down syndrome. I think we'll still remember Dr. Jayam, who was managing these things for the Downs in hospital here, and metabolic, inborn errors of metabolism, a lot of workshops, and people are getting more and more sensitive about it. And of course, immune disorders. When immunity goes to another extreme, you get into oncology. So I think chronic illness also helps us to understand the natural course of disease. Rapport building. Okay? In the dusty layers of time which Corona has brought, or even this climate change has brought, and internet technology has brought, is this rapport building coming down? I think you have to ask yourself this question and say what best you can do to do this rapport building. And especially this is mandatory for families with chronic illness. I think this is a thing which used to say that at one particular point they will say phenobarbital, phenytoin, and primidone. I think there was one Lancet editorial in which they say it's not that you need to go for very costly things. Phenobarbital is still a better drug, but the thing is the industry did not look at phenobarbital comfortably because you have to fill up a lot of registers, and after all it didn't bring much financial return. So as a result, the newer molecules gained a greater thing, and in fact after 1980, I think that was the time when it came resonant, you find the number of things which have gone up in the molecules which have gone up. They have their own plus and minus. So keep yourself updated so that it is not the pharmacy person who is going to tell you all these things are important, but I think we ourselves have to keep ourselves updated on these molecules. Okay. Two things is, as doctors, we manage diseases. No, we are not only managing disease, we manage problems. We have to manage problems for the family, and disease management is one aspect of that. Emotional support, financial support, if possible, wherever it is. And then, you see, there are people who give, I think the oncology, or Dr. Pushpa, the way in which she organized the thing for the for the anti-cancer drugs in Institute of Child Health is something which is to be emulated. And educational assistance, social integration, and of course psychosocial needs. So ladies and gentlemen, from being a teller and a controller, every pediatrician, or we expect the students to be a listener, sharer, and interpreter. Curiosity is what should drive. Don't poke your nose. Don't be curious about things which are not needed. Be curious about what really matters to the child. And I think that is what is the thing for which this patient has been brought here. He is having a chronic picture which is going on. What we see in the hospital is only a snapshot of his chronic illness which is running through. So help the family to understand, and of course trust. Capitals of infrastructure has improved. Capitals of manpower has improved. But capitals of social trust, I leave it to you. So next thing is, in the ward rounds, are we training the next generation to do all these points with an adequate history, assess the information, and understand the natural course of the disease? And I think you are the best judge of your own residents. Because if they don't understand things properly, they are in fact endangering the public, which are things. And where does the fault lie? Okay, we can try to make a root cause analysis, but then the measures to correct sometimes are ignored and inadequate. Okay, now I go into another different angle where our forensic medicine department and knowing laws also become important, because child abuse requires a very fine judgment. And it is often ignored because we are worried that we may be asked to come to the court and then testify. Or the family may get a bad name in the community, so better leave it. So at least one thing is at least follow the guidelines for safeguarding children in your own area or in your own hospital, because you find that every day there is a child abuse note which keeps on coming in the newspapers. So the important thing is what the mind does not know, the eye cannot see. When you look at a child, when you have all these things, a history is inconsistent, inappropriate focus, lack of supervision, developmental delay, all these children are likely to be abused. Because, you know, there is a primary or a secondary malnutrition. Primary malnutrition is in people who are dependent on others for their food. The pediatrics and the geriatrics people and the people who are in custodial care or the people who are in homes, they suffer from malnutrition, but they also suffer from child abuse. Uncommon patterns of injury and environmental stresses is away from the hospital. So it's a complex problem, but I think this is something which we also have to take some part in handling this. So you need to not only look at the updated guidelines, you must know what is happening in the pharmacology industry, and as well as this is the initial snakebite guidelines which came in 2008 from the ministry. And then, of course, snakebite is not neglected but frequently hijacked, because as I told you yesterday, when there is an industrial interest, a medical interest gets created. So sometimes whatever has been routinely followed, now phenobarbital nobody bothers, still it is still a good drug. So like that, you know, you need to look at the guidelines which are appropriate, and there should not be any resistance. So lukewarm support was there initially, but now people are definitely following these guidelines. Another important thing is, what should my child is now joined this course, what should he buy, sir? In the book, I will always say that buy a color atlas. A color atlas, because not that we will have an occasion to see all types of cases which get mentioned in conferences or in this thing. You may have occasional report. So I think a color atlas of physical diagnosis can be like your drug dosage book, like Dr. Jason Unni had tried to give a drug dosage book here, and Dr. BRS has a drug dosage book which is coming up. Similarly, one small color atlas, if they can have, that will help them to understand some of these conditions, because they have a visual enhancement. Because a generation for the last 15 years have grown through visual enhancement. So recognize and manage child abuse, it helps you, and it is essential for the practice to manage. And there, of course, direct patient care is the best teacher, and now whether offline rounds are getting replaced by online rounds. Patients narray illa sir, so even that exam we will conduct it through online. I mean, it's all right. Change is the only truth of life, and we need to do our best based on an objective care. Visual recognition is important. Now, another thing is your own record keeping also sometimes important. Now, in 2000, I think I had the occasion to go through this child with a hypothyroidism and note the date, ask him to just get a photo and ask them to put the date. And then you see this particular child going through from 2000 when he came. You understand about hypothyroidism, constipation. That is how they will just say. Maybe he's constipated, so the mother does not have to wash these nappies very often. So that itself is an indication that there is a hypothyroid child we may be having. Or when the child is crying, so these are all small clues which comes from the neighbors, but probably so there is every opportunity which gets missed, but at the same time, when they want to follow their children through these visual things, they find, and ultimately you find that this was a hypothyroid child from 2018. He came, and then he has grown with his own certain limitations, but then he has grown and life has taken care of it. Research, yes, is research possible in clinical practice? Dr. Bavaskar has shown. And one thing about research is, research patient pocket. But at some point or other, if you take time for research, you are treating people of the next generation by your results, positive or negative. If it is a negative result, don't pursue that line. You follow some other line. Of course, protocols force medical and caretakers to respond. Algorithms prevent leaving treatment chance. And we need to keep with literature, because new knowledge means change in practice. So this is how I think the scorpion antivenom thing came up along with the prazosin. And the important thing is, whatever you do, document it. take it to the next level of evidence, because we say evidence-based means it has to go at least for a systematic review when you are publishing it. Initially, it can be just an anecdotal experience. Collect all that. That is how research on HIV started, case with one case report. Then after that, it went in for a vaccine trial, and now that is within 20 years, there is so much of change in literature. So this is the thing of giving anti-scorpion venom with prazosin, in which the close monitoring helps you in decreasing the cardiac morbidity. The best example we have is morning we had Dr. VBR award, in which Lighty Cocktail and Dr. Gajalakshmi, who was the professor of physiology, she supported him in Stanley in doing these things on Lighty Cocktail. And the mortality was 20 to 29%. Then subsequently, we had prazosin, chlorpromazine. Even chlorpromazine had an alpha blocking effect. So that may be the reason why in some cases chlorpromazine helped. Of course, nitroglycerin and nitroprusside, now we know what is their value. And of course, now after Bhavaskar's push, and then we have understood that it is a pharmacological antidote. It is not the specific antidote, but now we are giving specific antidote as well as a pharmacological antidote. So remember, research is, we cannot say that it is not possible in it. Okay, where there is a will, there is a way. So how to treat? So you have things on a systematic review, whether steroids versus placebo, pain relief for lidocaine, prazosin with just only supportive therapy. There are ethical issues, because now that we have proved that prazosin definitely helps, you cannot just give somebody just only a supportive therapy. So these are all the ways by which research has progressed. Dengue. I think I was so happy that morning to look at the dengue score paper being presented. Important to talk about common diseases which affect our community. We require more and more doctors who can treat common diseases well. It doesn't mean that the specialty should not be developed. Specialty will always develop depending upon your interest. A dengue shock, you remember, I always used to ask the students, what is that thing which they have put in the leg of this child, especially the bandage? That is nothing but an intraosseous infusion which had gone into the child as he landed up in our emergency, and then subsequently he improved. And I always remember Dr. Balasubramaniam used to say the dengue people have got what is called tomato palm and tomato sauce. I mean, it's a way to remember. Like that, you know. So these are all certain telltale clues to your dengue, and of course compartmental syndrome and other things, fluid accumulation. Very important is keep the data. The data on death is, of course, cannot be falsified, because death data has to go, because it also has got a relevance to, say, property ownership, death certificate, and so many other things. So the death data is always available, and of course, we have to get into these kind of pictures. Like today, in the newborn, they had put the Indian picture about what is happening for the breast milk bank. So look at data, because data helps the policy makers to provide you resources. So don't look at data as some sort of, monthly report. It is not that. This has got this kind of a value which the burden on the National Zero Survey is helping. So if at all, Dr. Thangavelu is doing a wonderful job on the dengue things and making things so well. And I think this is a very common problem which we need to look at. Ladies and gentlemen, I am just one slide away from closing this speech, and I owe it to my mentor and teacher, Professor I.C. Verma, who's basically started the WHO Collaborating Center for Genetics in All India Institute. And of course, he was with us in JIPMER. Dr. Jagannath, who helped me to understand about mycobacterial proteins for my doctoral research, and he's in the University of Texas. Dr. Bhavaskar, about whom I have shared with you, and Dr. Ian Simpson. After that, he went to Pakistan, and where he made the Pakistan Medical Council accept our Indian National Snakebite Protocol. So he used to tell me as a joke, that's the only time when Pakistan agreed with India. And subsequently, he is now in Burkina Faso and doing again their things on snakebite. So ladies and gentlemen, we can hold two ideas at the same time. Things which are not all that normal and all that good are going on. Bad things are going on, but many things are getting better. So let us hold two ideas at the same time. Update your knowledge. The world will keep changing. Surround yourself with positive people, like-minded enthusiasts. When they surround us, I think our working ambience becomes excellent. Thanks indeed for your time and patience.
I request the audience for a standing ovation for the orator. Thank you so much, sir, for taking us through your travel. IAP TNSC is indeed pleased and honored to have you as our orator for the day. We next move to the...
One second. Thank you, Professor Mahadevan, sir. It was really a wonderful lecture. It appeared to me like a prism. Every facet of it was interesting. One facet, it showed your humbleness, the way you described your friends, the way you described your guru, the way you taught, the way you learned. The second facet, I loved it, was the message was very clear to the practitioners. That is, one thing is you actively listen and effectively communicate. That is a very good lesson. I took it from your slides. That is talking with the parents, not talking to them. That was a very wonderful message. If everybody follows that, I think the half of the problem is solved, sir. And of course, the third one, if you are known for that snake bite, you are a doyen in that field. Of course, you are given how to go about it. And as you rightly admitted, that I have learned the instrumentation now, how to go about it. And especially, you caution the teachers how to treat the students. Especially, they are not being controlled properly. My teachers, my guru in ICH and in MBBS, especially Dr. T.K. Ganesan, we used to very friendly, but they punished us appropriately. That is why we are all here in a good way. But nowadays, I think most of them are not like that. Anyhow, sir, this lecture proved useful to all, and I congratulate you and thank you for your thing.
Thank you, sir. We have the next scientific session. The speaker,
Mahadevan, you people know more for critical care as well as for snake venom and scorpion envenomation. But he has done so much for psychological problems in children, developmental pediatrics. He has been running the follow-up clinic along with Dr. Trivedi, Mrs. Trivedi, and he has given Srinivas Raghavan the impetus to take up developmental pediatrics. So they have done ADHD and autism, etc. And he has been looking after and following up them. And people will tell, no, he has been regularly doing for so many years. So that aspect, of course, he didn't touch. Probably he may be doing it in some other oration. But that is also a great contribution. No, people used to come and take. Thank you.
Is there one point which I can add with your permission, sir? Yes, sir. You see, we'll say, Mata, Pita, Guru, Devam. Of course, I talked about my gurus and how, of course, everything is determined by thing. But my Mata and Pita, my father was a postal employee. And he used to say, you have to be like a postage stamp. Something small which is in the corner of a letter, it persists till its job is done. That is, till it is delivered to the person to whom it is addressed. So, I think it is that persistence and patience which will ultimately bring us the thing which we want. Initially, it may appear everything challenging, whether nadakuma, nadakada, no. I think don't lose hope. Persistence and patience, like the postage stamp, is what my father used to say. And I think here, I recall, it is their thing which brought me here. Thank you.
Excellent, Jesse.
thank you, sirs. The next scientific session, my teacher, Professor Dr. S. Lakshmi Velmurugan, will now give her talk on rational combination antibiotic therapy in pediatric practice. I now request Dr. G. Venkatesh, sir, President IAP Chennai City Branch, to chair the session.